Great.
Yes.
All right. Well, hello, everyone. My name is Brian Patterson. I am at the uh, UW Health and the UW School of Medicine and Public Health, where I'm the Physician Administrative Director for Clinical AI. Clinically, I practice as an emergency physician. I am the first of the three of us to go today. And the plan is that each one of us is going to go through a few minutes of slides. For those of you who saw the AMIA presentation, I apologize. These are reprise slides, but the questions will be different as they are live. So hopefully there will still be plenty of value for you. But the goal is for each of us to just go through a few slides and kind of talk about different areas of focus or what we've been thinking about on these sort of front lines of large language model deployment in large health systems and uh, talk about some barriers, facilitators, and uh, topics of interest. So I'm going to get started. And what I want to talk about today is a little bit about how we measure and monitor LLM deployments within the context of our operational AI program and governance. So first, real briefly about UW Health. We are a large tertiary care medical center located in Wisconsin, South Central Wisconsin, and Madison, the capital. And we have a fairly large outpatient uh, practice throughout the state as well, with a presence in Northern Illinois with another hospital there. And we have been implementing AI tools since the early 20 teens. And have had AI governance in place. And what I'm going to talk about is like what's changed very recently for us. I would say that before last year, most AI tools were typically charged by the use. Like if we were, purchasing from a vendor, for instance, a tool that drafted a patient message reply, we're paying for each of those patient message replies. Or if we're getting a new feature that's AI, we're paying very separately for the AI feature. And one of the big things that happened over the course of last year into this year is that these AI tools are increasingly bundled as part of platforms and tools we already have. Vendors are consolidating their AI offerings and selling them as packages. And then other vendors who weren't in the AI space are kind of offering these like now with AI sections on their tools. And rather than pricing them separately, increasingly we see it as, oh, this is part of the contract you already have. Um, and what that leads to is a change in the alignment of incentives. In the earlier case, when we have to pay by the tool, when we're making the decision to turn these things on, we have people like myself who are concerned with safety and oversight of AI, who are saying, we need to study this, we need to make sure that it is safe and effective before it's turned on. We have maybe clinicians, whoever's championing the tool, saying, hey, I want to turn this on. And then we have somebody on the health system operational side saying, okay, what's the ROI? We need to study it. So me and some of the operational leadership are all aligned that we need to study this thing and prove that it has value. Once we switch into bundling it with something else, it moves that operational leader from the camp of me saying, let's take a look and see how this thing works over to the camp of let's just turn it on. We're already paying for it. Like we need to get the value for the thing that we've already invested in. And that's not entirely a bad thing. I think often in AI deployments, there's been this, history of these endless pilots and people not moving as fast as we could in an area where technology is clearly moving faster and helping. And we should move really fast in places where we know clinical risk of a tool is very low or its clinical safety is established. Um, we should move fast where we think the change management is minimal. This is some AI tool that's going to obviously improve a workflow and not change the way you do things. And we should move fast when the cost is minimal or already priced in, but that cost needs to be considered holistically. Just because something is free from a vendor doesn't mean it doesn't take our IS teams a ton of time to configure and put these tools in place, a ton of time to monitor them afterwards, and then it doesn't take our clinicians a long period of time to get used to using the tools, all of which is costly. So some examples of places where we've moved pretty fast are in the area of, a text assistant, which can adjust clinical text, many of our non-clinical tools, and then things that are already FDA approved, the safety profile is well established, they're used in a clear niche. Like if we think about imaging tools, like a tool that can look at a retina scan and look for risk of diabetic retinopathy. That's the example of it, the type of thing that probably doesn't need as much of this sort of pilot model stuff that we've been doing. That being said, there are places where monitoring is more crucial than ever. And those are places where clinical safety isn't yet established. I think that we're increasingly seeing this trend in which we put these AI tools out there that give clinicians advice, and clinicians use that advice to move sort of beyond the top of what you would consider their license to be. As an emergency doc, if I'm getting AI advice on what to do I stop calling my specialist as often, and when is that appropriate? Um, AI tools where change management is required. So this is the right now we're at this like great space where we're at the top of the hype cycle. All our providers want AI tools. If we need to educate them that we're putting these things in place where we're using up that change budget that we have, and we have this goodwill for the tools, and we don't want to burn that on tools that aren't worth it. Um, the other place where we want to monitor is places where we're not sure the value that we're getting. And we need to avoid that sort of false equivalency that there's no added vendor cost means this is a free tool. As I said, the cost of measuring and monitoring support. And so how do we think about monitoring large language models? One of the challenges, we're already pretty good, and many places are at our governance with machine learning models. We know that to turn one of these tools on, we need to validate the model, we need to understand its test characteristics, we need to we have a set of patient outcomes we're looking to influence that we can check. And fitting LLMs into that governance is part of what many people have done. How do we use our Gen AI features the same way? But one of the challenges is we don't have easy to monitor metrics for a lot of LLM tools. When we think about, hey, if we're writing a summary to give to a clinician of a patient, or if we're writing a note on behalf of a physician, or we're drafting a message to send to a patient, there's no sensitivity or specificity of that process. So how do we fit these things into the same task? So for us, what we do is we try to say that we may not be able to measure all LLM use cases with the same metrics, but we do need to be able to answer the same basic questions. So the idea we have is if we want to monitor this, we need to have a set of computable, monitorable metrics to answer at least a couple of these questions. Is it safe for every tool? And then at least one of these other four questions. Does it save time? Do our providers like it? Does it improve care quality? Does it improve the patient experience? We need to be able to find a computable metric that we're going to say this answers this question. And the idea is that hopefully we can provide a toolbox of available metrics, which will grow over time, so that as more and more of these large language models come out and start to look the same, we can take tools from our toolbox to measure each one of these. For instance, when we draft responses to our MyChart messages, our safety metric is based on the edit distance between the draft and the sent messages, and then a percent of messages that have been edited. That allows us to see if providers are perhaps not editing their messages at all, which suggests that maybe they're not reading them before they send it out. We're succumbing to automation bias. For our effectiveness metric, we use a simple how many drafts are used by providers divided by the drafts generated to say like how many times do providers choose with their clicks whether they're going to use this tool. For outpatient notes summarization, where we're summarizing a bunch of notes and giving them to clinicians, it's a completely different set of metrics to answer the same questions. So we say, when we look at safety, we have a metric where we look at the number of negative feedback events we get per number of summaries generated, and then we use a validated score, the PDSQI-9 score, which we administer with large language models in batches to try to ensure consistency of the summarization product over time. And then for effectiveness, similarly, we just look at a simple metric of how many summaries are viewed of the ones that we generate in places where we can see what views are. And the idea of having these metrics in place means that we can go back to our old paradigm of making our approval contingent on having a good monitoring plan. With the challenge here being that we want to make sure that everything that's getting out there is getting monitored, but not necessarily slow down those places where we need to move fast. We need to be agile with, the increasing volume of things that are coming out. And for things that don't have a huge change management budget or are easy to do, we need to pick metrics that are easy to generate, easy to monitor, so that we don't slow ourselves down by creating a huge extra cost and monitoring burden. All right, and that is the end of my slides here. I think we're going to take questions at the end, and I'm going to turn things over to Dr. Tarabishi for a talk about mental health.
Thank you, Dr. Patterson. Let me do my screen share. All right, coming across? You guys hear me, see me? All right, thumbs up. Thank you.
Yes.
All right, so Yasser Terabishi, I am a pulmonary and critical care doc, physician informaticist, and several informatics roles at Metro Health, including Chief Health AI Officer. So real pleasure to get this group back together again. No conflicts. Briefly, Metro Health is a big safety net system in Cleveland, Ohio. We are, I think, just in terms of informatics capabilities and know-how, we punch above our weight. And so there's a bunch of accolades that we can look at. I'm going to mirror what Brian's mentioned. We've been doing AI and AI governance for several years now, and we are cranking up maturity and trying to think about where the space is going. So a lot of this is getting really good at the basic principles with prediction, analytics, life cycle concepts around managing AI solutions from beginning to end. But now it's obviously getting a lot more complicated. And so, we do have full multidisciplinary committees for governance. We're thinking a lot about generative AI and agentic solutions. We are really currently obsessed about upskilling our workforce so they understand both risks and opportunities in this space. Everybody needs to be on board. And we're trying to move from just kind of incidental monitoring to really having infrastructure for monitoring. And what has changed is the volume of use cases. They are absolutely exploding. And I'm sure many of you have read that recent article in NEJMAI about shadow AI, and the inability to drink from the fire hose means your end users are definitely going elsewhere for their solutions. So that's an active problem we're working through. What hasn't changed is the core principles. The seriousness with which we evaluate solutions, holding vendors and operational owners accountable, really expecting a clear assessment of failure modes and how we mitigate risk. And like I said, embracing the lifecycle standard, primarily around triggers for scaling and decommissioning. So trying to bake that into the process so that it's clear at the outset. One of the questions I think that came up prior to this talk, I guess during registration, people are asking about governance. I know that the question already dropped into the chat. It's a journey to right size governance. So what I've tried to do here is really think through the core kind of design patterns that really can make your governance work. In my mind, governance, responsible AI implementation needs to work like a really efficient IRB. Like not a bad IRB, but a really efficient IRB, meaning when you're putting in an application for a solution, the rules are clear enough, the application simple enough that you probably know what the outcome of that application is. Heck, you can outsource the evaluation of said solution to operational stakeholders in the organization. So it's not just a couple of people holding the regulatory responsibility keys. And so you want to make that intake really clear. For solutions that require internal evaluation, you want to have an opportunity to sandbox it or turn it on silently, really clearly have predefined tiers for import and risk, clear operational ownership, success metrics are clearly outlined. And when people are putting in these solutions, there's got to be a plan. Like how are we monitoring this? Who's responsible for monitoring it, et cetera. So switching gears to large language models specifically, I think, a little bit of a showcase for what we've done at Metro. I've bucketed these out generically, just in my mind. Information retrieval tools, drafting tools like patient messages or clinical notes, tools that suggest things like clinical documentation, CDI, level of service, for instance, discretizing data from narrative data to objective discrete data items. And then I think interacting is more what we're starting to do with patient guidance. So interactive tools with patients. So how are we approaching vendors and building in the space? We really fast follow when tools are safe and mature, and some of that is EHR native. We partner to co-develop when really developers out there don't meet our need, and we have an opportunity to co-develop and co-invest in a solution. And we really are investing in educating end users around the limitations of these solutions. And really the driving point for a lot of these large language models, it's not just utilization, it's feedback, feedback, feedback. And not is it only feedback, you want to empower your end users to provide feedback, but we want to hold our vendors and developers accountable to be responsive to said feedback so that the feedback actually matters, so that we can tell our end users that we care about your feedback. Please continue to administer. The concerns we have as a safety net system, several studies have shown that if you just take a clinical narrative and you swap out demographic information or mention that a patient, for instance, is unhoused, will have an impact on the recommendation of a large language model clinical decision support system. So, for instance, if you have a patient with GI symptoms and you mention unhoused in the narrative, it's more likely to basically throw it off as a mental health condition rather than a true condition, a clinical condition, a medical condition, I should say, requiring evaluation. So these are the concerns we have when we think about the impact of these solutions in our system. The other concern that we're actively engaged with on the development side with the GME, the graduate medical education. So it's trainees and how they're starting to interact with these tools, be it clinical support or documentation support, or even ambient listening, for example. The introduction of such solution hypothetically could stunt development or growth in terms of skilling. And so we are trying to collect as much information. We are trying to approach these conversations thoughtfully, but we're also trying not to frustrate progress, right? So I mean, we can have so many analogies in the airline industry and others about or intubation using assistive devices or not. At some point, the technology does better, and we need to embrace that. But we also need to train our end users for independent thought process, critical reasoning, and kind of teach them or coach them through how to actually work with these solutions rather than be replaced by them. So here's a busy slide, but it's a fun one. We had two options, I think, to kind of demonstrate the tension in terms of build versus buy when it comes to generative AI solutions. We had the option to use an incumbent vendor. We had the option to go with a third-party vendor. The incumbent vendor submitted EHR data to a generic cloud service, one of the frontier models, with prompting, and brought the data back. No guardrails, no assurance, no quality oversight. Just, I think this is fine, or this has worked, right, for a lot of other users. The reason we decided to go a different way is we worked with a third-party vendor that not only had, quality assurance and a level of validation on top of the solution, they also had board-certified clinicians that reviewed this. These are I should have said these are patient summaries and discharge summaries for patients that are in the inpatient setting. And so we have random review of documentation by board-certified clinicians with well-defined safety thresholds, clear accountability in terms of who's following what. So, if you say yes or no when it comes to satisfaction with the tool, there's a follow-through and a redevelopment of the tooling with feedback to our team to say, hey, one of your end users identified a hallucination. We think this is a problem, and here's how we're going to mitigate this going forward. And so that ties into the next item, which is continuous monitoring reporting. We have bias and equity surveillance that they're doing on their end, again, swapping out demographic information to make sure that the model doesn't misbehave, and then control change management. So, well-packaged understanding of what's coming out next in the solution space, which has actually been, I think, Brian alludes to this, a big pain point, the scope creep. Every vendor's coming at, AI opportunity from different angles. Your ambient AI solution is trying to do CDS. Your CDS is now doing ambient AI. It's all kind of colliding into each other. So I just wanted to show a little bit of data from our solution. There's a name there, but we don't need to talk about the name. This is all preliminary data that we're working on, but we saw a good spike in inpatient, hospitalists, attendings, residents using these tools to generate progress notes and discharge summaries up to 80% of potential users, with about an average uptake per user of just peaking over 40% more recently. So good widespread use, a decent amount of use per note. So we think good utilization. We're looking at note edit times as a measure of efficiency in this space, and this is an interrupted time series to just kind of show you where it was before and where it is now. Counterfactual being the pink line, blue showing a reduction in edit times, which is really exciting, I think, just conceptually. And some preliminary data on heterogeneity. The bottom line is not everybody responds positively to the tool. A lot of people get so the lower you go on this graph, a big delta, an improvement in their time to completing their discharge summaries. Some people not so much. There's a bit of a a negative trend to that line, but I'm not going to overread it. I think this is all just to say there's not a one size fits all expectation for pre-post. And this is all length of stay and comorbidity adjusted time for no completion. The money is really in case mix index. So case mix index is a measure of your complexity for your admitted patients. It affects your billing, your DRG, and basically gives you a sense for how much we might be able to be reimbursed for a certain admission. And there's a general thought here in the inpatient space is that we often undercode and underbill. So we're not getting the money that we think we're earned or owed, right, based on the complexity of the patient or the care that we've provided. And this is just showing you that we've looked at length of stays across the organization for people that have used the tool versus people that have not. And we're showing that actually does improve coding. So we have increase in codes, and we have an increase in the case mix index, which does not seem huge, but a marginal change in case mix index multiplied over a large number of patients does actually, at least in our system, equal millions of dollars, which more than pays for this kind of a tool. So the summary really, thousands of discharge summaries later, good uptake, about a 10% reduction in documentation time, and we had a self-reported reduction in cognitive burden, which was great to see, with an improvement in coding and build complexity. So I think kind of a bunch of operational and clinical wins when it comes to this particular Gen AI tool. I mentioned this at the AMIA meet, and I think it's worth talking about again, but just the question of building or buying, it's really you need to know the system in which you operate. You need to know the resources. And I think the buy, partner, build construct really depends on what you're trying to do and what you can do. The biggest constraint for a system like Metro Health as a safety net system, it's not just the money, it's the bandwidth. It's the bandwidth to integrate and not just integrate, manage change and monitor something post-deployment. So that means sometimes we're going to have to pay for that. We're going to have to pay a vendor to do that for us. Lessons, wins, share, learn from others, co-design with end users. This one's highlighted for a reason. Solve workflow, not AI. It's all about workflow. And I think this is particularly true as we get into the agentic space. Continuing to use, high-tech solutions and agents to continue to complete broken workflows is highly problematic. A lot of the work that we do on the informatics side when it comes to AI implementation really just kind of unearths problems and workflows where the answer is like, hey, what if we just did it differently? And you actually don't need AI for this problem. Commit to deployment and decommissioning plans, have a clear benefit statement so that everybody up front knows what to expect. Change management is crucial with anything that you're doing in the healthcare space. And then you need feedback loops and constant monitoring. Things that, I wish we could do differently after having been burned on these many times before. We've had executives say, we need this. It's going to be great. No clear ownership, right? No champions on the ground, and things get orphaned. Things are left on. High cost, high risk, right? Of this being misused because no one's actually watching it. Expensive creep and overlap and bloat. I think I've already beat that one up. You have to strategically consolidate. Our end users are being pulled in multiple different directions. There are vendors out there that allow them to use their tool, claim their tool is HIPAA compliant, and then turn around and ask healthcare systems to sign a BAA. So it's really coercive, but unfortunately, that's the reality of the space that we're in. Novelty, I think, Brian mentioned this, it's very shiny and exciting. I think that's starting to fade a little bit. I think people are starting to get over the large language models, and now they're thinking agents are going to just do everything for them. So I think it's just the next new shiny object. But same constraints. If you haven't figured out workflow without governance or utility, you're not going to make any success. Never assume vendor maturity is clinical safety. Even incumbents that are jumping into this space eagerly, I think are likely making mistakes, potentially regrettable ones in the space. And at the end of the day, we are responsible. They are completely indemnified by definition. They provide tools, we use them. If something bad happens, it's because we used their tool poorly. So you cannot outsource that responsibility. That is your system's responsibility. Don't underestimate integration costs all the time. You need to be monitoring safety and equity signals at the outset as soon as you turn this thing on. And adoption is great, but it's not the end all be all. And I think we have to go beyond that. All right, and I will pass it over to Dr. Zhang.
Thank you. Thank you, Dr. Tarabishi, for the great talk, and Dr. Patterson as well. Can you see my slides? Is it coming up?
Almost there.
Loading, yeah.
You got it.
Coming up? Okay,
Yes.
great. Okay, thank you. Um, so I think the previous two talks were focused on governance, and there was a lot of mention around vendor products and the tension between build and buy. So my portion is I was thinking about focusing on the research side of LLMs for health systems. So at the beginning of the slide of this call, there were the logos of many of the HYPE members, and I noticed many of them have academic medical centers. So I'm thinking that if you're participating in HYPE, you might be thinking about how do we translate the researchers' hard work on LLM-based research into health systems kind of pilot or even build into workflow, taking it closer to real-world implementation. So I come from kind of both sides of the health systems. I'm both a faculty in Weill Cornell in the Department of Population Health and Emergency Medicine, and I'm also an informatics director at New York-Presbyterian, where I also represent our health systems for HYPE along with our CDO, Dr. Beth Percha. So my talk, I thought that would focus on how we have been thinking about research at Weill Cornell and New York-Presbyterian, and what are our approaches or thought process around translation. So, wearing my researcher's hat first, I think many of you, if you're regular to Health AI Partnership, we're coming to these kind of AI implementation talks. These are no-brainers to you. There are several kind of success factors to AI adoption. And as we move from traditional ML to now the latest shiny sub objects of LLMs and agents, somewhat the conceptual factors remain the same. I think my two previous panelists have mentioned some of these, but those are kind of the social factors around the cultures of health delivery, the absolute need for safety, and the consideration for how AI fits into the organization as opposed to it just being its standalone tool. And there are also the technical factors that I think are really interesting, especially as we move towards traditional ML, which primarily is around getting predictions, telling you what factors are driving to the predictions. To now we're generating documents, we're trying to have conversations, and we're trying to have agents even try to do reasoning. So there's a lot of potential in terms of what AI can deliver that's closer to how clinicians or the whole healthcare team might be thinking about. So we at New York Presbyterian, we have similar vendor products that our two previous panelists have mentioned. These kind of have no longer is the latest tools, but we have been doing the monitoring. For example, my colleagues at New York Presbyterian have been doing pilots of DAX, and I think there was recently a JAMA paper that did the implementation evaluation of the ambient scribing of 5 health systems with similar findings, which is that yes, there is some reduction to the note-taking time, as well as some reduction in the pajama time, but not as much as what might have been kind of publicized by the vendor. And similarly, we are a Epic shop. We also have colleagues at both Weill Cornell and Columbia, which are both affiliated with our health systems at NYP to do a joint evaluation of the Epic art tool. And then they have seen similar adoption trends that probably you have seen in other places in presentations as well. So my focus is to say that yes, we have quite a bit of vendor products. I think the latest number that I've seen from our AI governance is that we have over 120 AI products are currently going through AI governance. Some of them are LLMs, some of them are traditional ML. But what I want to focus, as I mentioned, is really what about research, right? I want to be, as Dr. Terabishi mentioned, I want to be one of those, responsible builder, responsible researchers, but at the same time, I also want to disrupt current healthcare, remove redundancies, inefficiencies. So bringing my researchers, how can I do it in a responsible way? How can I move as quickly as I can through the IRB process, the AI governance process, while really discovering new scientific knowledge that potentially, can impact patient care in a positive way. So just very, very quickly, because I'm part of our emergency medicine, this is one example that we're currently building as part of our NIH R01 study with Vanderbilt University. The focus is really not the main focus here. I mean, the problem is not the main focus here, but just to talk you through it so that you understand what kind of prediction tasks we're doing. The problem here that we are trying to do is kind of an overall focus of our health systems effort to improve patient flow. So we would love to understand how can we use AI to improve emergency, for example, patient volume forecast, understand how we're getting patients through the discharge process, understanding if we are missing anyone who might benefit from additional transitions of care between emergency medicine to potentially, for example, home care or virtual care. So we're trying to use an LLM to understand if we can predict patients who are at risk upon emergency department discharge, and especially we have a composite outcome which we labeled as emergency department return visits plus admissions. So this outcome focus on not just return visits, but we look at only the specific few percentile of patients who have admissions in their return visits. So as part of this work, we are aware just based on kind of our experience so far with trying to build AI and translate into the clinical workflow. We understand that we need to build AI prediction model, regardless of whether it's traditional ML or large language model, but we also actually need to understand what is the new subsequent intervention. And in my observation and in my personal research, I find that this has been really the critical piece that many AI translation studies tend to miss is that we cannot just provide an AI output and expect that to naturally fit into the workflow. Sometimes we actually have to design the subsequent interventions. And especially, I think that might be the case now that we have LLMs and agents, which can do a lot more things than the traditional ML. So what our group, kind of the research group at the emergency department and health system is there is a team of expert emergency medicine clinicians who have done a large number of chart reviews of patients who had return visits and needed hospital admissions. So they went through the index visit diagnosis classification. They went through the root causes, and they're in the middle of trying to understand for each prediction of a certain subphenotype of the patients who have return visits, what kind of factors drive these return visit plus admissions, and what kind of intervention might actually prevent it. And what we're pairing these design of clinical potentially novel subsequent intervention is the LLMs. So our team has a two-stage LLMs to predict the RVAs. The first stage is to have the LLM summarize everything that the LLM can see based on the current ED notes, but also going back in history to search if the patients have any relevant information from their ambulatory visits or prior ED or hospital admissions. And this LLM would also then do the prediction for us, as well as identifying which downstream subsequent intervention the patient might benefit from. And so this is all very research-like, but as I mentioned, we are trying to translate this into production, into part of the workflow in our health system. So naturally, cost is a concern or a definitely a consideration for us. So I think that when we do this type of research, we we need to face the reality of how much would it cost for us to run this on a daily basis, especially in our emergency departments, the patient volume can be very high throughout the year. So we're doing this within Epic. There's the new Cogito data science environment that allow us to query Clarity directly and can use various sorts of APIs ranging from GPT-4 to 5. And so we're kind of comparing performance versus in terms of higher capacity model versus lower and the cost and the reasoning and the predictive performance. This is in collaboration between us at Weill Cornell / NYP as well as Vanderbilt University. And while we're doing this, I think another piece of information that, from a research perspective, and probably to justify the financial need of the LLM, is really to understand how good is AI, right? Because yes, we as researchers or probably health systems leaders, we want to see our health systems being the frontier of national AI dialogue. We want to push the frontier, but also how good is AI? We have to compare AI against actual clinical judgments. We have to compare AI against the existing clinical scores, and of course, the ground truth. So what we're doing is we're conducting a prospective patient enrollment study where for each patient, if you can see this plot here, we are comparing the ISAR score, which is a clinical score to assess an elderly patient's frailty or vulnerability. It's an existing clinical score. And on the y-axis is the clinician's assessment of how much the patient is at risk after they're discharged from the emergency department. And so as you can see, this is a randomly enrolled patient sample at Cornell ED. So what this is showing you that there is a wide variety of clinician assessment of risk and the existing clinical scores assessment. So this actually gives you a sense of how complex the problem might be. And it also, if you look at the red dots, where that is where the ground truth patients with this return visit admission, which is the outcome that we're trying to predict, happens. So this plot we think is a motivating kind of evidence that if this is a problem that is really hard enough, and if AI can have a higher performance compared to existing workflow and assist clinician judgment, then I think is where it makes sense for us to push towards real world implementation and evaluation. So I'll skip this, but I think the reasoning aspects of LLMs is definitely something that should be considered, and how we evaluate the reasoning is a huge bottleneck because this requires a lot of clinician time in assessing and in reading the AI reasoning outputs. So there's a lot of work that can be done, but also for these work to move towards real workflow, I think is going to be a considerable amount of time and collaboration with the regulatory body as well as AI governance committees. So I'll just quickly kind of close my portion to say that because I wear both hats as researchers and also someone who is in health systems operations, I oftentimes think about kind of what are the factors that we need to consider for AI to be successful, and when can AI projects when might fail. So one kind of thing that you might remember if you attended our AMIA talk last year was kind of the contrast between a PhD person and an MD person, and how should the two group of people come together and do AI deployment. So that wasn't a joke back then in AMIA. We actually published a paper around this topic, the impacts of leadership on AI deployment study outcomes in healthcare, where we compared um, if you have a clinical leader as the main person driving the implementation, as opposed to a PhD person driving the implementation, which team is going to kind of, is there any difference? And we're so far actually, this is not to say that each AI deployment should be led by a clinical leadership, but our finding definitely backs the argument that clinicians need to be involved and researchers and clinicians together need to be thinking about implementation to, together. So with that, I think those are all my slides, and I think we're ready for questions. Thank you.
Okay, thank you all so much. I am going to open up the floor for questions. I know we already have some in the chat, so I'm going to get started with those. Anu, would you like to come off mute and ask, or I can kind of read them out?
Uh, I have a few questions. Yeah, you can go ahead and ask them. I think hopefully they're all worth it. I don't know. It just felt exciting to hear them talk so much. And it is just positive experience. I mean, today I think this is the second webinar that I came across, and that was a different perspective I had in the previous one, where they really are more clinical, like Ms. Zhang said, like both of them have to collaborate and then come up with a solution that truly helps healthcare. So with that in mind, yeah, you can go ahead and ask my questions, Sierra. Thank you
Okay.
so much.
Yes, of course. So the first one I'm seeing, which I know we've talked about a little bit, but I will ask anyway to see if there's anything you all would like to add, is what does the governance piece look like to ensure that AI is accountable and that there is a human factor, or essentially a human in the loop to act as a guardrail?
I'm trying to find the people on the screen here. Brian, you want to
Yeah,
go?
I could take a swing at it. I think we've talked a lot about governance in this forum, and I don't want to go over like the whole like how should AI governance work. I think what I would say is like the most recent lessons is with this huge volume, we've really tried to pare down what is the function of our governance system and in turning from saying it's governance, it's prioritization, so as to AI safety and oversight. Like the goal of this governance system is to say that the most important question is this safe and effective, this tool, and focusing this monitoring evaluation around safety and effectiveness and kind of like leaving it to other parts of the system to say like, hey, should we pay for this? Should we is this appropriate for our physicians in this space versus that space? Trying to, I think as AI kind of diffuses through our organizations, we can't say like the central AI team makes every decision because then we're running the whole hospital. And so I think kind of like really toning down that role of the central AI team has been an important factor for us.
Yeah, I'll say I'm increasingly convinced that, and I said as much, you have an IRB-like function that looks at responsibility, like is this reasonable? And then you have a steering group that's thinking about strategy and prioritization and scope. And you also need activated operational owners who come to the table and say, this is what's important to us in our space. These are opportunities. Uh, and then you need to stitch that all together. I think that's, who that magical like unicorn person in the middle who's bringing all these people together. That's a hard one. I can tell you we're thinking about putting job descriptions for that person. I would have rethought my career choices in hindsight because there's a lot of action in that space. Uh, but it needs to come there's like down, it's pushed down, and it needs to also come from the organization at the lowest levels, all the way up. So that's kind of the system that we are building. Obviously, it's going to depend on your size, the size of your organization. I'm going to comment a little bit about the human in the loop. I'll say like when we first started, there's this whole alarmist positioning of nothing will ever happen unless a clinician or a subject matter expert or a person like allows it to happen. And I think that as we've gotten a little bit more comfortable with the tooling, you start to wonder if that's always true, and it's probably not always true. And I'd argue that there are likely organizations that are already starting to break that, even in healthcare, not just back office, operations, but even in healthcare. Quality review of notes, risk assessment for patients. I mean, we're already starting to do these things, and these things invariably drive downstream consequences, whether or not a clinician is sitting there saying yes, no, yes, no, yes, no. And you can argue that the position of a user saying yes, no is not reassuring. Like automation bias is real. We all deal with it. We've been dealing with it. As a clinician, let's think about like training today. When I used to, well, I've always been in the HR, but let's say a couple of years before I started, you would have to write a prescription out on a piece of paper, which means you actually had to know like the dose of the medication, right? The like all the prescription characteristics that you think about when you're prescribing. Now you just start writing Zosyn and you just accept the first thing that comes up on your screen because you're like, somebody probably set this up correctly. So like we have always been in the automation bias business. This just accentuates it. And so the whole person in the loop safety guardrail, like that is not a reassuring guardrail. I have concerns about that. And so I think we have to make sure that whatever guardrails we're placing, whatever kind of checks, they are risk concordant. So if you're going to bop the clinician on the head every single time something happens, we are either just going to accept it and walk on or quit our jobs, right? Like this is not assistive tech anymore. And I think that you really don't need to interrupt somebody when there is a risk consideration or a true impact that requires a clinical judgment. Um, and that's the balance. So no, I don't think it's always clinician or end user in the loop. I am concerned about that paradigm. It just throws all the burden back on your clinician.
Can I ask something on that note? Like, how about compliance? Like, is compliance something you can incorporate instead of blaming it on either clinicians or operations or the IT? Like, what about compliance? How does
Yes.
compliance management officer, whoever that is for that organization,
Uh,
will they be the ones making sure everybody's accountable for what is happening?
so there's always somebody who ends up holding the bag. In the clinical sphere, like a clinician's name is going to be implicated. And that's why, again, we have to design safety first, risk concordant checks and balances without overwhelming the end user. Oh, it's kind of like, I'll give you another practical example. I'm an intensivist. I am on call at night. I go to sleep. I have a team of residents, fellows, medical students that are taking care of really sick patients, and things could happen. Even if I'm still sleeping through it, if I wake up and bad things have happened, God forbid, has not happened, uh, I'm accountable to that, right? Like your AI agents, in this case, your clinical end users, have decided that everything is fine and I'm going to keep operating in this capacity, and then maybe someone has a bad outcome, right? Like we live in that world. Like this is not a net new problem that we're trying to solve for. This is an ongoing liability concern, and unfortunately, like I said, it always ends up being on someone's license, which is exactly why clinicians are not just going to go away. They're not going to disappear, because I'll tell you, the EHR vendors and the vendors of AI solutions do not want that liability. They are not interested in that liability. They are more than happy to throw it back at the healthcare systems.
Yeah, and I fully agree. And I also think that when we talk about human in the loop, there is kind of a divide between the conversation that we have in forums like this, where everyone is quite informed on the latest knowledge, with the reality that when patients are asking questions to ChatGPT, there's no human in the loop. And so when we are discussing how do we make AI safe in the hospital settings, you have patients asking ChatGPT, should I go to the emergency department, right? So I think there is a recent paper that I believe came out of Nature Medicine where they did an evaluation of ChatGPT Health's response to emergency triage, and only half of them were correct. So I think that that we have, and that is part of the reason is because we're just letting these vendors develop products, and we have no researchers and we have no IRB approved studies for researchers to develop and test these chatbots. So researchers are kind of their hands are tied because of compliance issues, because of the need to do clinical trials and monitor for adverse events, while these vendors are going in the wild completely while no human in the loop and assisting patients with all sorts of questions. So I think that that's a really big problem that I see. And that is an elephant that I think needs to be talked more about when we talk about human in the loop.
Okay, I think this next question tags on well to that ChatGPT health paper. How have you seen the use of AI impact patient engagement in terms of their acceptance or not acceptance of AI use in clinical care?
I have some sort of unpublished data on this. We've been doing some interviews with patients when they come in to see how they feel about using AI. I think there's a lot of work out there that looks at patient attitudes towards AI, and I think what we're finding is it's all over the place. I think when you go out and ask patients, there's some who are super distrustful of AI, don't want it anywhere near their doctor. They don't want people making decisions based on that. And then there are others you know, who are saying this is great. If it's making everything else better, it can probably make you a little smarter too. Like, why don't you use as much AI as you can when you take care of me? And I think it's a little dangerous. What I'm taking away from this is it's a little dangerous to say patients want X or patients want Y when we talk about engagement with AI. Um, because what we're finding is that each patient's an individual person. Their opinions on this may vary even more widely than the providers. But I do think we need to get to a place where we have a rational framework for what should we be telling patients when we're using AI? How should we be telling patients to engage with AI that is a little bit more sophisticated than a lot of the regulatory stuff that you're seeing on the state level coming through? It's like you have to tell a patient every time you're using AI. That hasn't come to my state yet, but those types of like one size fits all solutions are in my mind more likely to create like compliant but useless workarounds than to actually improve the conversation. I don't want my patients to have to sign a card when they come into the hospital, or they might be monitored by one of like 300 models.
which we've always been doing, right?
Yeah,
And everyone's thinking about it.
yeah.
Anything Dr. Tarabucci or Dr. Zhang to add?
That was good.
Okay, we'll move on to the next question. As you continue to use tools that have been approved by the system, how often do you think about what it looks like to continuously monitor and reassess those tools?
I'm going to read that question again.
I interpreted it my,
I was going
my
to say,
way.
that's not my thing.
Yeah, can I say that? No, what I meant to
Yeah,
say was
please.
Yeah.
you're using your AI tool, and then you got to the point where you start trusting it enough. So you want to make it better, or you want to see something more, or whatever you're seeing. Like, for example, it's a baseline that you are able to accept it or trust it, and then you want to improvise it to make it better. Like, for example, like when you document, you start documenting in a way, and then you find out a way to document more effectively, more efficiently, that you get much better data like that. That's the quality. Are you able to improve the quality of that um, AI-driven solution? That's where I was going with this. If you think it's doing enough, are you able to refine it and then make it better, not only to improve, but if something is incomplete or inadequate, are you able to make it better? That's the refined part I wanted to know. Sorry if it's too much.
No, that's good. I'll give you the generative AI tooling answer. It depends. I think one of the challenges is like if you decide I want this tool to summarize a patient's journey in their hospital stay, like their discharge summary, as we call it. So the end of the hospitalization, the summarization of a patient's discharge, their whole course, and where they're going, the outcome, and what the plan is when they leave the hospital. If you ask 20 different providers what it should look like to be effective, you're going to get completely different answers. So what ends up having to happen is you create like an average expectation, which people like, I would say 20, 15 people are okay with, 5 people hate, but nobody loves, versus trying to cater to 3 people that are going to love it and then realizing everyone's going to hate it. So the ability to improve that kind of output in a way where it's satisfying to everybody would require an immense amount of like retraining within users. And I don't know of any systems that have reached that level of complexity, nor do I think I actually want to see that, because then all of a sudden the variability of the solution is going to, like, the heterogeneity of the outcome is going to explode. And so now I'm having to try to understand why Dr. So-and-so's version of the tool has adapted to a place that's dangerous or concerning or less accurate versus, this other, Dr. B or Dr. C, right? So I think right now it's an interesting problem. I, recursive, like, self-learning is a promise. So improvement of models over time, retraining. I think we only think about that when there's drift, when there's an opportunity to retrain a model for a specific outcome, or if there's differences within demographics that we have to adjust, like at a population level. But I think this kind of like notion of self-learning, self-healing, adapting is A, concerning from a healthcare responsibility perspective, and B, I don't think like really scalable. Not yet, at least. I'm sure Dr. Zhang is working on such systems, but we're not. I don't see that in practice. I don't think we're there yet.
Oops. Okay. I know that we are at time and a little over, so I am going to stop us there. But if you have additional questions, please feel free to email them to us, and I am happy to pass them along to the authors and speakers. Thank you all again for your presentation today. We really appreciate it. We were excited to be able to bring you all back to recreate this. And let's see if my screen share will cooperate with me. We just have a quick feedback survey. If you all have additional questions, topics of interest, or other comments about the presentation, we would love to get your feedback. You can fill out that survey by scanning the link at the QR code. And thank you all so much for joining us today.
Thank you.